Right, we have pneumonia. We introduced it to you. Just look at the epidemiology of this problem. As already mentioned, pneumonia is dangerous, right? And with increasing age, the probability of death increases. With the use of antibiotics, the younger population who get the pneumonia, the death has decreased, right? So this is actually to do much with the resistance of the patient also, right? So as people age and have other complications, the resistance decreases, right? Sound up. Okay, we will sound up. I had to sound up. Right? I have to talk loud, which is a little difficult, but I have to do it. Right? Okay. I move the laptop a little closer so that might help. Okay. Now, so there is the general incidence that is given here, right? Mostly worldwide incidence is probably, right? And in subpopulations, right? Or groups of right people, example like in the HIV, the probability of getting pneumonia is higher, that's obviously, right? And more so with people who use IV drugs also, right? Including people with HIV and IV drug, this added incentive for getting bacterial pneumonia, right? The other important thing that we already have now noted is that most pneumonia are going to be bacterial. And we also said that almost all is with the exception of about 10 to 15% of pneumonia could be viral. And so there are viral pneumonias, but not common as the bacteria. Right? Right. So then there are again a lot of classifications for pneumonias, right? Various types. So again, these are all, what shall we say, not fixed, right? Depends on many criteria. Different people might use it differently, depending on how they are looking at the problem, right? So example is the anatomical location, right? So very famous pneumonia is what we call lobal pneumonia, right? A lobe is affected, right? So a particular lobe might be affected, is localized to that lobe, right? Then also it can be diffuse, right? Why is that? Somebody says can't hear. Share sound, height, pause, check. Is this with everybody? Samsung says can't hear. All the others are also having the same problem. I'm all okay as usual. Remote pause. Let me see. Can't hear properly. What is this? Speakers. Audio setting. Let's see the audio setting. Microphone. Volume. Speaker.
Where can I talk?
How is it now? You feel okay now?
Yes, sir.
Okay. Now okay. Right. So some people are agreeing now it's okay. Right. Right. So then we have the localized pneumonia, which can be local pneumonia, right? And then the diffuse one, which can be spread into different lobes and different bronchioles affected, which is typically known as bronchopneumonia. Right? So then you have multiple lobes and both sides of the lungs, right? Affected with actually consolidation, right? That's the pathological term for what happens in the lung during pneumonia, right? So I think you might believe that. It's called consolidation, right? You heard that word? Or is it new? You know what is consolidation? Anybody who has heard of consolidation? You have heard of consolidation, yes or no? Somebody can tell me. We have heard consolidation, yes. Anybody has heard consolidation? Nobody? I'm waiting for a chat answer. Somebody can say yes or no. That's it. See the level of pathology that you all know. 109 people, nobody can tell me whether they have heard yes for consolidation and no consolidation. Yes, somebody. Please tell. Nobody. I want to know or yes. Two answers. No. Oh gosh. Who knows? Right. So then I can't do pathology here, right? I can advise you. You must go and find what is meant by consolidation in pneumonia. Right? The pathological process of consolidation in pneumonia. That's very important. Right? You can just read only that. Right? Any pathology book or Google it, I think you will be able to find it. Right? That will tell you a lot of information about what pneumonia pathologically is and what happens in the lung and in the alveoli and in the ways, right? So that's very important because on that one we go about treating and managing and then examination wise, right? The physical signs that you get all are related to this phenomena that we call the consolidation, right? Okay? Right. So you have to do that homework for yourself, assuming this is a sample of your batch. Two people were given saying no, right? Please do that homework, otherwise it's difficult to understand the physical signs and also the process of pneumonia. I have not touched much on that thing because that's partly pathology, right? Yeah. So then there is something called also, we said about pathology, etiology we told that it can be viral or bacterial and majority bacterial, right? But then there can be also something we call atypical, right? Those days also we used to say, right, that the atypical, the viral also is added to the atypical, right? So when we say atypical pneumonia, it means atypical, it means viral also, right? But then we have now found a lot of other organisms which are not bacteria, but there are other organisms, right? So again, you have to do your what you call microbiology, right, to find out what these organisms are. Right? Chlamydia you would have heard, right? So chlamydia can cause pneumonia, and then Legionella, right? And then Coxiella burnetii. Right? So these are organisms when they cause various diseases, right? Other than pneumonia, right? But they can cause pneumonia also, right? So when they cause a pneumonia, then these are called atypical pneumonias. So organisms are atypical, not the common bacteria that we find in majority of cases, right? So as you see the second paragraph, they have told us that now they have stopped using it, but still you will find that old people, old physicians, old pathologists sometimes using these words, and sometimes even the books you will still see them, right? Still they will talk about the causes for atypical, right? So that's easily understood. So here's the breakup there, right? So when they say that, right, there can be also a certain other problem. There is a small variety of pneumonia that can be caused by this 5% is caused by that, right? What is that? Aspiration of vomit, right? Or actually it should be vomitus, right? And or radiotherapy and or allergic mechanisms, right? So these three things mentioned also can cause a pneumonia, right? So again, I'm not going to explain all that in detail. You can, it's evident, you know what is aspiration of vomitus, right? And then the radiotherapy, post radiotherapy, you have inflammation of the lung. If you have some cancer somewhere, which is needs radiotherapy, and you have to expose your lung to it, you can have post radiation pneumonia, right? And allergies also can cause certain pneumonias, right? So those are the etiological classification you can talk of, we told you. anatomically we can talk of it. Then we can talk of it as etiological agents, right? So all that is also covered. Then, so these are actually theoretically we will talk of these terms, maybe to explain, to treat, and to various people will use it at various situations according to their field of study and research, right? But when it comes to treatment, right, one of the most useful things is what we classify as community acquired and hospital acquired pneumonias, right? So if you acquire the pneumonia while in hospital, right, then it's going to be hospital acquired pneumonias, right? So again, that's the big story behind that. But otherwise, the majority of pneumonias who come from the community, right? You got a pneumonia and you get admitted to hospital to be treated for the pneumonia that you contracted while outside the hospital. Right? So those are very easy things for actually, that is for treating the pneumonia and also managing the pneumonia. Obviously, it's very easy to look at it that way because of the causatory organism which can cause these two types, right? So here is a small chart which tells you the community acquired variety and the hospital acquired variety, right? And which prognosis, right? And then the organisms involved, right? So in give it a read, you can see that, right? The acquired ones, the community acquired ones are generally good prognosis, right? Usually it's younger patients, right? And then in the hospital acquired ones, you find it is defined as a pneumonia that develops 48 hours after admission, right? Because the hospital environment has a lot of resistant organisms, right? Resistant organisms are found in hospital setting, and comorbid conditions of patients usually will cause acquired hospital acquired pneumonia, right? And the organisms you can see are gram-negative, right? Bacillus, Staphylococcus aureus, right? And they can be usually drug-resistant organisms. Okay. But community acquired is usually these two well-known bacteria, right? One is Streptococcus pneumonia, right? And then the Haemophilus influenzae, and then anaerobes are rare, right? Other rare organisms, again, as we have told you, right? Mycoplasma, Legionella, Chlamydia, right? These are rare organisms which can be acquired from the community, right? There is no difference here in the hospital acquired variety. Same goes for them, right? Right. Then we look at certain precipitating factors which can cause a pneumonia, right? What are the precipitating factors? It can be a viral infection, right? And secondarily, you are getting infected with a Streptococcus pneumonia, right? Obviously, hospitalization, we already told you, right? Can be gram-negative. Cigarette smoking is very important, right? It's a good precipitating factor. Alcohol excess is another factor. Bronchiectasis, right? We already discussed bronchiectasis, so it can also precipitate a pneumonia, right? Especially in a cystic fibrosis patient who the cystic fibrosis patients are already having a bronchiectatic lung, right? Then any sort of bronchial obstruction, right? So the common one would be carcinoma. Immunosuppression due to various causes, right? And then IV drug use, right? Dysphagia, right, can cause aspiration, as we already know, right? Any sort of dysphagia will is prone to aspiration. So you can have aspiration, right? So we have problems with the esophagus and also that is any lesion in the esophagus. Then other than that, there can be some coordination disorders of the esophageal peristalsis, right? These are again large amount of discussion we can do on these things, but they are all rare, right? But we have to know that these are also part of the precipitating factors for pneumonia, right? Right. So we come to the symptoms. Typically, the hospital variety or the non-hospital variety, anything is going to be the same, right? When it comes to symptoms, right? The initial ones, the main common ones, right? So we're talking about the main common one. There will be shortness of breath, right? There will be shortness of breath. There will be a cough, right? May be productive in adolescents and adults, right? And you have to note that it can be dry and non-productive in infants and elderly, right? See that? Very important, right? So at the extremes of age, you might not find a cough, you might not find initially, right? So this is, we are talking of the first, maybe the first 24 hours, right? So that's the important thing, right? Within 24 hours, if you don't diagnose a pneumonia, you don't have a chance, right? The patient might die, right? So this is the, I'm just telling by experience, right? I don't know. The books will give you more informed statistics, right? It's very aggressive. You have to aggressively treat, right? Otherwise, the patient is going to die. So, delay in diagnosis is going to be giving you a poor prognosis. So, you got that shortness of breath, cough, obviously the fever, right? Fever is going to be high fever, right? You can have rigors, you can have vomiting, you can have headache, you can have loss of appetite, right? And depending on comorbid conditions, you can have hemoptysis or even certain pneumonia, you can have frank hemoptysis, right? Depending on the agent, right? This pleuritic chest pain, right? Because of the inflammation of the pleura, right? The pleura is involved next to the lung, so you can have a pleuritic chest pain. Right? What is pleuritic chest pain? You can have pain, referred pain to the shoulder, right? That's from the diaphragmatic pleura. Or you can have the pain referred to the anterior abdominal wall, right? So you're going to be misled by thinking pneumonia patient is having, right? How can a pneumonia patient have pain in the abdomen? Because it is in butter pain. Epigastrium is subcostal margin එකේ පැත්තට. ඉතින් ඔයා හිතන්නේ දැන් මොකද? ස්පීන් එකේ නැත්නම් liver එකේ problem එකක් නැත්නම් gallbladder එකේ problem එකක් වෙන්න පුළුවන්. නැත්නම් gastritis වෙන්න පුළුවන් කියලා හිතන්න. හරිද? ඒ වුණාට this is referred pain. You have to know your anatomy. Then you will know that there is even the T10 is coming up to what? To the umbilicus, right? So you can have pleuritic chest pain referred to the abdomen. So you can have upper abdominal tenderness in some patients with low pneumonia, obvious, right? Signs of consolidation on examination and by chest X-ray, right? So that's why I told you you have to know what is consolidation, right? So what are the signs of consolidation, right? What is the sign of consolidation? consolidation, right? On examination, you will feel, right? You can hear bronchial breathing. If there is consolidation, you will have bronchial breathing, right? So the other thing is you can have on percussion dullness, right? Not stony dull, but you can have dullness on percussion, right? And then you have what we call whispering petrology, right? So these are the physical signs of consolidation, right? So if you really know the pathology, as I told you, go and read the pathology. You will know why there is bronchial breathing, right? The breath sounds of the bronchi can be heard on the chest surface of the lungs. I mean, through the lungs on the chest surface, right? And there will be dullness on percussion, right? So you have to go and read both consolidation and what is whispering. Okay, what is dullness, why you are getting dullness, and then also why you are getting bronchial breathing, right? So that has to be done by you with your homework if you don't know what is consolidation, right? Dyspnea. Did we talk of dyspnea before? See, shortness of breath. It only shortness of breath, right? Then we have said dyspnea again. Shortness of breath, dyspnea, both are going to be almost same, right? Because the patient is going to complain of difficulty breathing, then we will call it shortness of breath, but we will say it is difficulty breathing is defined by medical terminology, we call it dyspnea, right? What is tachypnea? So can you have dyspnea and tachypnea both together? Right? So this is where a lot of clinical terms and things get used properly, and you should know their real meaning or proper meanings, right? A lot of people confuse this. They think dyspnea and tachypnea both are same, and then in the middle they'll go and put shortness of breath in the into the frying pan, right? So shortness of breath is patient is going to come and tell you. Then you will write dyspnea, which is what we call shortness of breath, right? Tachypnea is the rate of the breathing is faster than normal. Right? Similarly, tachycardia is the rate of the pulse is faster than normal. And so you have to know your normals. And so if you know your normal, then you know this is tachypnea, right? And this is tachycardia. And shortness of breath is going to be useful. Why I am taking this very slowly is that these are the most important signs in pneumonia, right? And you have to pick it up very fast, meaning you have to look at the patient and say, this is pneumonia, right? When you have the pleuritic chest pain, it's very difficult to breathe up and down, right? So with every breath, there will be severe pain. So the patient has now not enough, the tidal volume, the amount of air coming in and going out is very less now for the patient because he can't breathe in and out properly. So what happens? Because of that, the patient will have rapid breathing, right? And also due to the difficulty in breathing, he will say, I'm having difficulty in breathing because he cannot move the air in and out, right? It's all consolidated, the alveoli, right? So you will have this patient with sort of unable to breathe in and out properly and breathing, saying that he's having difficulty to breathe. And then he'll be breathing very short, fast breaths, right? And if there is pleuritic chest pain, he will be having as he breathes begins in at close to the peak of inspiration, whatever level he is inspiring, you will have a catch in the breath. You will have a catch in the breath. That's the term you use. Right? This is easily observable and noted by the physicians or doctors who have a hawk eye. Hawk eye. Eagle වගේ කරකෙන මේවා තියෙනවානේ birds වලට කියන්නේ hawk කියලා eagle වගේ. Or you can have a hawk eye or eagle eye. Right? So you should have as a medical student and as a doctor, that your vision should be very focused on the patient's physical signs, and this is one of the things which I am explaining to you. People miss, right? They take a long time to think, patient ayala thiyena, cancer thiyena, una thiyena, popori thiyena, I think me katak thiyenawani, right? Bronchitis wenna puluwan kiyala hitagena. Eyanata me physical signs tika takala note karana. Patient ne andun galwala balanna ඕනේ. ඒ කියන්නේ at least you have to strip the patient up to the pubic symphysis. Put the patient seated or put the patient 45 degrees or put the patient supine, which the patient will not like to do. And then observe the patient for few minutes, right? You can even diagnose pneumonia by looking at the patient, right? Auscultating patient and just percussion and auscultation and palpation, right? So these are very easily done. You don't have hi-fi instruments, right? Even X-ray is only just to confirm your suspicion, right? So please be very vigilant about this physical signs, right? In an acutely ill patient, usually you have to take good care of this clinical information that is easily available on the patient, right? The last one is not important for us, right? Ventilated patients. Right. So that's what I just now told you, right? Rapid shallow breathing with a pleural rub, right? Is very, very important to be noted, right? There is something called confusion, right? Which can be due to the hypoxia in elderly people, right? So elderly patient will have no or not, most of the physical signs that we now told you might be missing in a patient initially who is very old. And old people are prone to pneumonia, right? And so many comorbidities are there, and we told you the information about that, right? So these people can come to hospital confused, right? Even a fever might not be very well established because the body's defenses are very weak, right? The physical signs that a normal, robust immune mechanism can exhibit is not found in the elderly patients, right? Same can happen with the infants and the young children, right? So remember this. You find someone suddenly coming, patient is having confusion and you see a little difficult breathing, tachypnea, right? No fever, don't think it is. You can just ignore the patient, you have to examine the patient, right? So this is where the examination part comes very useful. Oxygen saturation. Now these are all when in the hospital setting, right? So you can't check hospital saturation in your dispensary or clinic or at home, right? Mostly nowadays it's available, right? But if there is saturation dropping below the normal, then you have to think of these things, right? Yeah. So what is the important thing you can see here, right? Infiltration, consolidation, right? All this can be seen with X-rays, right? But before the X-ray appears, you can check the patient physically, right? That will give you evidence. Sometimes the X-ray changes might take 48 hours after the first symptoms, right? So these are all a catch in the diagnosis when these are delayed. also you have the other thing when if the patient has not died and you're treating the patient, when you're following up the patient after discharge from the hospital after 2 weeks or 3 weeks or whatever, right? The 1 week after discharge, you will review the patient again, and then you can take follow-up X-rays, right? Then we see changes will take time to resolve, right? So if the changes are not resolving properly, then you have to be suspicious of other comorbid condition, very commonly cancer in the patient, which could have led to your initial presentation of pneumonia. Right? So these are all things to be vigilant about. So here the example of lobe pneumonia, right middle lobe consolidation as drawn on the X-ray. Right? So these are the pictures that you see. Right. So this is what we mean by consolidation. Right? So this is a picture of consolidation. Right? Again, you see consolidation in this lobe here, right? Left lung. Here again, consolidation on this, right? Obviously, this is a patient with probably in the ICU under monitoring, right? Being monitored. The ECG leads leading, showing up as the wires, right? Right. So once the patient is identified as a pneumonia, right? What they do is they will a good place, a good medical facility, right? They will do blood cultures, right? To assess for bacteremia and also all these other baseline blood tests which are going to be obviously no, right? So the full blood count, right? The white blood cell count will be high, the ESR will be high, the CRP will be high, right? And then anemia can be there, right? Which can point to abscess formation, right? This complication of pneumonia, right? And usually we don't do all those things. We can do the full blood count, ESR and stuff like that. But as a routine, we don't usually do this blood culture. We will go on. If you do a blood culture, you have to do the culture and then you have to do ABS, antibiotic sensitivity test is done to confirm that the antibiotic that you are using on the patient is responding or is affecting the organism that you have in the patient, right? If there is pleural fluid or pleural effusion is there, then you can do aspiration, right? Or if there is empyema or abscess, right? You can do aspiration to get a direct hold on the organism, right? In severe pneumonia, Legionella is secreted in the urine. Now we told you Legionella is the agent which is the antigen of Legionella, right? Not the Legionella itself is secreted in the urine. So that's if you suspect Legionella, we can usually try to detect it in the urine. Right? So these are high fighters. These are not usually done unless you are suspecting these things, right? There is a thing called a curve score, right, which is to assess the severity of the acquired pneumonia. Right, it predicts the risk of mortality for the patient. Right, each factor of the score is worth 1 point, and they have this scoring system, right, which gives you the risk as less than 1, and then 5 years, 60% risk. Right? So this is the curve is given here for you, right? So confusion urea greater than 7, respiratory rate greater than 30 per minute, blood pressure falling below systolic 90 and diastolic 60, and the age as 65. Right? So this is called curve 65. And we told you that most of them can most of the elderly people are going to be having high mortality. The confusion is actually part of that story, right? So if the score is greater than 3, then severe pneumonia, right? Greater than 2 requires hospitalization. That is that curve score is useful for managing the patient. Right? Differential diagnosis for these people, right? Obviously, these things can be entertained, pulmonary embolism, right? You don't have the short sort of history that you have in pneumonia, but you have to keep an eye on the diagnosis or the possibility. Right? The shortness of breath is more likely to be more sudden than in pneumonia, but pneumonia is also sudden, right? But not as sudden as pulmonary embolism. Right? So that's the only distinguishing feature, right? Then you can have TB, right, as a TB, and then pulmonary edema, right? Pulmonary edema could also be a differential diagnosis, right? So treatment, right? Obviously, we have to IV drugs, correct the hydration, prop up the shock if that's there, and then give oxygen, right? And monitor progress, right? So that's the treatment that we do. Right. So these are the finer points in management. I don't think you will need all those finer points, right? But you can read if you want, right? These are the complications that might come up with these patients, right? There can be sepsis, right? Septicemia, that can give you a hypotension, right? And then you can have a lot of other problems with the hypotension, right? Atrial fibrillation is common in elderly patients with pneumonia, right? That's a complication of pneumonia. So that can be treated with temporarily with a short-term stint of giving digoxin. Right? Pleural effusion is also another complication of pneumonia. Right? So again, you have to do drainage of the patient if necessary. Right? So these are again complications. The pleural effusion can lead to can get infected. Then it's called empyema, that is pus in the pleural space. Right? Right. So empyema is again a big problem, right? After effusion, if the effusion is there and then it becomes infected, then the fever will not go down. There will be spiking of the fever, right? And then you can have all these physical signs, dullness, right? Reduced sounds, right? And pleural rub, right? Decreased chest expansion. Those are the physical signs that we see with empyema, right? So this is treatment methods, right? So again, fluid aspiration, chest drainage, right? Also, antibiotic therapy is very important, and this is how we choose the antibiotics. And sometimes we have to give the antibiotic and review the antibiotic whether it's working, even up to 4 to 6 weeks, right? Global collapse is another complication, and thromboembolism is another complication, right? And then also pneumothorax is a complication of pneumonia, which is well known with this organism, which is called Staphylococcus aureus, right? cerebral aureus can cause pneumothorax as a complication, right? Late complications, right? So the patient is not recovering as expected, right? Not resolving the resolution of the pneumonia. Right? In young patients, it resolves, right? Easily, right? With the support of the antibiotic and the nursing care, right? But if there is a comorbid condition, right, the patient can go into what we call a lung abscess, right? So you will find the fever is not going down, right? It's spiking, right? Then you have to think of emphysema or lung abscess, right? Or some other complicating mechanism like something like a bronchial carcinoma, right? So which is not allowing the lesion or the pneumonia to resolve completely, right? So that's the lung abscess complication, right? So lung abscess is also common with these people, right? So alcoholics, people with foreign bodies, cerebral blockage, whether it is lesion or a cancer or even a problem with the mechanism of the peristalsis, example like Chagas disease or multiple palsy, right? And or the bronchial carcinoma, right? So these all can cause aspiration pneumonias, which can lead to a lung abscess. Right? So pathologically, these we are discussing some of the organisms here, right? Klebsiella pneumonia, Strep aureus. These are very toxic or bacteria that can cause multiple lung abscesses, right? And they can cause what we call septic emboli, right? It can spread to other parts of the body through the lung, through the lymphatics or the veins or the arteries even, and cause a lot of complications, right? So these are some of these things that can cause. Remember, lung abscess, if they start developing a lung abscess, right, they have a very bad smell coming out of the patient. The sputum is very purulent, right? And then the fever, the malaise, the anemia, the weight loss will occur very fast on these patients, and they can even have clubbing occurring if the patient is going to be dragging along for a longer time, right? Right. So these are the X-rays, investigations you will do, right? Basically, we have done all that, right? Sputum sample for microscopy can be also very helpful in treating the patient, right? And then here is the lung abscess, right? So the lung abscess can be easily identified with an X-ray when you see a fluid level in the abscess, right? In the consolidation chamber, right? And for looking for why you are having a complication, you can do a bronchoscopy, which can be very helpful in resolving the cause for the lung abscess, right? So again, treatment is very complicated. You have to treat the patient for a long time. For the lung abscess, you have to locate the lung abscess and then give proper postural drainage, which is in the team has to discuss it, and then physiotherapist has to know how to give the postural drainage, right? So this is sort of very important when it comes to the lung abscess, right? So septicemia is another complication of this condition, right? It can also have all these other complications coming along with it, right? So infective enteritis, meningitis, right, can happen when the bacteria enter the bloodstream and you end up with a septicemia, right? So patient is very unwell, right? And then we can have patient going into adult respiratory distress syndrome, ARDS, or even renal failure, or what we call multi-organ failure, right? And we can have even what we call ectopic abscesses. That means abscesses which are now forming due to the especially Staph aureus, can go outside the lung, right? So you can have hepatitis, pericarditis, myocarditis, right? All these things also can be part of the story, right? This is the most common pneumonia that we told, the organism, right? And I told you very high fever, that's the high fever you're going to have, 39.5, right? And very, you can initially come with a thoracic pain and a dry cough, right? After a few days, the cough can become productive, and then typically the sputum is described as rust-colored sputum, right? The breathing becomes rapid, shallow, decreased chest expansion on that side. This is a very important physical sign when you do it, when you are doing palpation, right? So you have to be trained how to do the examination for chest expansion, right? So this is a big problem now, right? So clinical training for you, I think, is almost zero now, right? So you are losing on that part of the story. I don't know for how long, right? Anyway, that's how we are now managing medical education without a touch, right? Without a touch of a patient, right? And then also the pleural rub can be also heard, right? Again, needs practice and examination technique to listen to a pleural rub, right? So these are the groups of people who might get these sort of organisms, right? So we are just learning a list, you can easily see that, right? Right. So I have included one of your topics, which is the chest X-ray, right? So I'm going to give part of that here because the pneumonia is obviously more involved, as we told you. To confirm the diagnosis, you can take X-ray. And then the other part of the X-ray reading will be found with your, what is that, the pneumothorax, right? So both of those will give you part information about reading a chest X-ray, which is also part of your syllabus topics that they have given for discussion, right? So system for X-ray reading. We are talking of X-ray reading of the chest, right? So what is that? That's going to be what we call a plain chest X-ray. Right? So we call a plain chest X-ray or PA view, which is the normal one that we should usually take, right? So when you get the chest X-ray, what is the important thing, right? Any doctor should be very careful about reading the X-ray and telling the findings of the X-ray to anybody. You have to be sure that it is the X-ray of the patient, right? Because X-rays can get mixed up, right? It can get mixed up in the X-ray unit, it can be mixed up in transit, and it can be mixed up in the ward, right? So here you will be checking the patient's chest X-ray, whether it is the correct person, it is the correct view you wanted, and name is there, the age is there, right? And you can even ask the patient, cover the X-ray ගන්න. patient කට මතක තියෙනවනේ ගොඩක් අයට X-ray ගන්න එක අර selfie ගන්නවා වගේ කැලලක් නෙවෙයිනේ අර. So they will say ඊයේ තමයි මගේ X-ray ගත්තේ. ආපු ගමන් ඉතින් ඔක ගෙදරටත් ගන්නවනේ මෙයාගේ X-ray ගත්තා කියලා. ඒ මට මතකයි. right? ඉතින් මෙයා කිව්වොත් එහෙම පෙරේද ගත්තා. ඒ වුණාට date එක තියෙන්නේ ඊයේ. ඒතකොට අර දන්නා මේ X-ray එක මෙයාගේ නෙවෙයි. හරිද? මේ වගේ ගොඩක් mistake වෙලා තියෙනවා. I don't know if somebody is laughing or crying. I think somebody is crying a lot. Anyway, so that is the important thing to be sure about the X-ray of the patient, right? Then you have to look at the orientation, as I already said, the correct side of the patient, right? Then check the X-ray whether it's PA or AP, right? On an AP chest X-ray, the heart will look larger than it entities. Right? So you can't comment on the heart size if you have taken an AP X-ray. But normally we don't take a AP X-ray for looking at the lungs. Right? We take a normal, what we call, the normal is for us is a PA. Right? But you know what is AP and PA? I think hope you know. Right? Posterior anterior, antero posterior. Right? So that's what it means. That's depending on the exposure of the rays on the film through the patient. Right? Okay. So PA is actually posterior anterior. The rays, the X-rays will travel through the patient from behind to anterior. The film is kept anterior. That's, if you have taken X-ray, you will know, right? Normally, normal PA X-rays are what is taken, and you would have experienced it on a medical checkup, right? All right. So that is important to assess visual of the patient. Plus also, the PA is good for assessing the heart size. Then check the exposure. That's the number two thing that we should be doing. Right? We have to check the exposure and be sure that the exposure is correct. Right? So if you have overexposure, also you will not see what you want to see. If you have underexposed, also you will not see what you have to see. Right? So normal exposure is actually not in your hand; it is in the hand of the technician. But the X-ray is now in your hand, and you should be able to at least guess whether the exposure is good. Right? So how do you know that the exposure is reasonable? By trying to visualize on the X-ray film, the vertebrae should be just seen through the heart channel. Right? If it is too much exposed, it will look dark. If it is underexposed, it will look radio opaque, or what we call pale. Right? So I think the time is close. Let me see if we can see X-ray. It will explain what is it. Yeah. So the X-ray is coming later, right? After explaining all this, only the X-rays will come. So we will remember that to note when we see the X-rays, right? So I think we can stop here and then discuss A, B, C, D, E, F on the X-ray next week, right? Okay. So we stop here for now.